Welcome to those who are joining. I can see the numbers going up. This evening, I am chatting with Dr. Carol Gilling-Smith and the lovely Michelle from the Agora Fertility Clinic in Brighton. Welcome, ladies.
Thank you so much for having us.
And we're obviously going to be talking about a hugely insightful topic tonight, the COVID vaccine and fertility treatment. And we've been sent a huge amount of questions in advance, which I know that you've been looking at and have very, very useful slides to talk through in detail. So thank you for that. And I also wanted to start by saying a big thank you for being part of the Fertility Help Hub Fertility Clinics versus COVID initiative, which is running until the 10th of March, where you have very kindly generously donated a free cycle of IVF to support a couple or individual who have been affected by treatment and COVID in helping them restart their journey and have their longed for child. So thank you so much for being involved in this. It really is a huge thing and we're very, very grateful.
Absolute pleasure, and we're passionate about it being a great success, so, for those couples who are going to be able to get treatment.
And you've obviously seen, haven't you, in your own clinic, the heartbreak that COVID has caused and the anxiety, and to be able to do something like that to help is huge.
Yes, we're delighted. I think it's been a very hard, tough time for patients who want to conceive, and anything we can do, we're really pleased to do.
Fantastic. Well, I'm going to share my screen and we can start by moving on to the topic tonight. So if everyone can see my screen, we will be talking about the COVID vaccine and the fertility treatment in the UK. I'm Eloise, and for those of you who don't know me, can you see my screen, by the way?
It's a dark screen at the moment.
Oh, okay. Bear with me. Sorry, it's doing this thing where it's not showing the right screen. Can you see my screen now?
Yes.
Fantastic. Okay, so I started Fertility Help Hub in 2019, before COVID, having experienced difficulties myself, and I have 3 young sperm donor conceived children. My husband is infertile, so we have done IVF with donor conception, and I really struggled going through our own fertility journey to find relatable, reliable information in one place that wasn't overwhelming, and also really would have loved to have had a community of support during that time. So it brings together everything that we would have benefited from. And now I'll pass over to Carol and Michelle.
Wonderful.
So, hi, I'm Carol Gilling-Smith. I founded the Agora in 2007. We opened. For me, it was really, it's a passion for me to be able to help people have children. I have 3 children, and I think it was, I didn't have fertility treatment, but I think it's one of those gifts that you take for granted. And I really love my work, and everyone at the team knows that. And we have, obviously, we do IVF, we do all the fertility treatments. We have a very big interest in helping the LGBTQ community as well, because we're in Brighton, and because we believe that that everybody, whatever their reason for wanting a child, should be supported. And I'll introduce Michelle, because she's part of my team, but does a lot of the work communicating, if you like, the science to the patients. And she'll tell you a little bit more about her role as well.
Yes, so I very much take a lead role in a very sort of patient-facing role, actually. So I often will actually be taking a lot of calls from our patients, and particularly at the moment actually answering some of those slightly more difficult questions relating to COVID. And I also just ensure that the clinic is running really smoothly and as safely as possible at the moment as well.
Fantastic. Thank you for the introductions. Let's move on. Okay, so just a few bits of housekeeping. It will last approximately 1 hour. The Agora team have prepared some slides to help with updating everyone on COVID and the vaccine, and it's being recorded so that people can watch it back if they miss it. And if you have a question, please hit raise hand, and there's also a chat box. So at the end, we will do a Q&A. So for anything that hasn't been covered, or if you have any additional questions that you sent in from before, then please feel free to ask, and we will allow a time to do that. So that will be at the end. There's no need to say your name or put your camera on. You can be totally anonymous and just listen or ask questions as you wish. So welcome, the Agora.
Thank you. thank you very much. This looks a bit scientific, and I don't want this evening to turn out a little bit like those political meetings we have where, you know, there's a scientist from SAGE and the Prime Minister, and they're telling us all these things with statistics and so forth. I want this to be a very practical chat through. And one of the things that I think that is worrying patients is that they don't fully understand what a vaccine is or how it works. And of course, that then conjures up images of COVID being injected into the system, and hence many of the fears. So I'm just going to summarize, first of all, what we've got available. I think you've got to remember that normally vaccines take a long time to be made, and it's had to be quite a rush jobs for the scientists. But all over the world, different scientific laboratories have been looking at different technologies to generate a vaccine against this deadly virus. And we have at the moment approved for use in the UK the Pfizer vaccine. The Pfizer vaccine was the first one that was rolled out in December and had approval. So when a vaccine is first made, it has to be tested first in the lab, and then on animals, and then in patients, and then it has to go through a special scientific assessment by the UK regulators, and then it's passed for you. So Pfizer went through, and shortly afterwards, the second vaccine came out, which was the Oxford AstraZeneca vaccine. And then more recently, the Moderna has been approved. And you'll see in the, you know, in the brackets, I've put the type of vaccine. I've put there's the mRNA vaccine for the Pfizer and Moderna, and the viral vector. And I'm going to explain how they work. And coming fairly soon, there's a Novavax protein-based vaccine that is being currently tested. And a very recent addition is this Johnson & Johnson one. Now, the first four have a system where you give the initial dose of the vaccine, and a few weeks later, a booster dose is given. And that initial dose is really going to give your immune system a chance to build up. It's resistant to the coronavirus. And then the booster really kind of just takes that immunity right up. The beauty about the Johnson & Johnson is that it seems to be effective as a single dose, which is going to give it more practical use, particularly in underdeveloped countries where it's going to be difficult to administer 2 doses. Now, how does the vaccine work? Well, the whole point of the vaccine is to give you a tiny little taster of we can't really call it a taster, it's not a nice thing to have, but a taster of the coronavirus vaccine, so that you can build up an antibody response. And in some vaccines, you can also build up sort of a T cell, a white cell response. But let's work on just the antibody response. Now, here's a picture of the coronavirus vaccine. And there are 2 main elements that you need to focus on. One is the genetic material inside the virus. And then you've got this outer coat, or this envelope that contains it, which has proteins on the outside. And the spike protein in the coronavirus is what we're interested in when we come to vaccines. Because when the body recognizes the spike protein, that's when it can mount an immune response. And it's the most useful immune response possible, because the way that the virus attacks our cells is the spike protein gets into the body and it attaches itself to the surface of cells through these special receptors we call MACE receptors. And once it's invaded the cell, it can inject its genetic material into the cell, and it can then multiply and multiply and multiply. So if we can stop the virus from attaching to our cells, we can basically push it away and say, go away, you're not wanted here. Next slide, if you can, Eloise. So there are 3 different ways you can do this. And I'm going to start with the bottom line, because that's the way the Pfizer one works. And what it does is the Pfizer is basically a tiny bit of the genetic material from the virus, the mRNA part we call it, that codes for the spike protein. That's what's purified and injected in the vaccine. And it then makes your body produce the spike protein, not the virus, just this protein that's on the shell of the virus. And that then promotes your body to say, right, I need to make a defense to that, and you get antibodies to the spike protein. So that when the coronavirus, if it invades your body, gets in, you've got this wonderful antibody response. Well, that's what it's supposed to do. Now that takes 2 or 3 weeks to happen. So that's the mRNA vaccine. It's the newest type of vaccine available. It can be manufactured very, very quickly, unlike the others. But the Pfizer one has the disadvantage that it has to be stored at -70. So it's a little bit more difficult to actually give out to a large population. The second one, the one in the middle row of this diagram, is the one that's the Oxford, the AstraZeneca virus. So what you do there is you attach a little bit of the spike protein genetics to a vector, and they use a chimpanzee virus, something that won't harm you. So when it goes into the body, that virus is attenuated. It doesn't have any harm to you whatsoever. And attached to that, you've got this little bit of the protein gene, which promotes your body to produce, again, the spike protein. And that provokes your immune response. And then the third type, which is the new ones coming in, is a protein-based virus, which is a little bit of the spike protein, which has been purified and directly injected as the vaccine. And that provokes that antibody response. So that shows you 3 different types of vaccine, and we can't put them all into the same pool. But what I'm trying to say to you is, if you just focus on the spike protein, that's all that effectively the vaccine is getting into you. You're not putting coronavirus into the body. You're not putting anything harmful into the body. So when we are constantly asked these questions, is what danger could it cause me by having the vaccine? The main danger of having a vaccine is that your body's immune system might go a little bit into overdrive. And particularly with the Pfizer vaccine, the one that causes the mRNA vaccine, that one is particularly prone to causing, if we call it an anaphylactic reaction, an excessive immune response. Sometimes when people get a wasp sting, their whole hand blows up because they're getting an excessive response to that, to that toxin in their body. And it's the body trying to defend itself from the toxin. So occasionally, and very rarely, a vaccine can produce an overreaction, and you can become quite unwell with it. It's usually a short-term reaction. So for the moment, the Pfizer vaccine is not suitable for people who have, for example, an EpiPen because they've had a previous reaction to fish or shellfish or eggs or something like that. And they tend to be advised to have the Oxford vaccine at the moment. Next slide, please.
Wonderful. So I'm just going to take over here a little bit just to go through some of our frequently asked questions. So as I said before, one of the things that I've really been dealing with is answering with Carol's advice some of these questions that people are just so anxious about at the moment. So the first one is one of the vaccines safer or better than another if you're trying to conceive, and can you choose?
Well, you can't choose unless there's an underlying medical reason. And if there was an underlying medical reason around fertility, then you would be given the safer vaccine. But all the scientific studies to date have not shown a difference in the population of young men or women that are trying to conceive. So all the vaccines are perfectly reasonable to use if you're trying to conceive. Which really goes on to question number 2, which I'll answer, is actually the vaccines are perfectly safe and will not have a negative effect on your fertility. We know that. This is not my personal opinion. This is based on numerous evaluations of the vaccines, and that guidance has been published by the British Fertility Society, by the European Society of Human Reproduction, by the American Society, by the Committee on the Safety of Vaccines and Immunization. It's all been really carefully analysed. I don't know where this sort of notion that people's fertility could be negatively affected by the vaccine has come from. But Michelle, you were very worried, weren't you?
I was. I actually had a discussion. I've had my first dose of vaccine now, and I remember it was very sudden, and I was offered it virtually the next day, which was fantastic. And I remember, because Carol is actually my mother, I said to her, I was like, please, can you advise me of this? Can you tell me is it going to be safe for me to have, thinking about, you know, if I want to have a family in the future. And thankfully she did fully reassure me. We went over the science of it, and I think there is quite a lot of scaremongering online about it, because people haven't really understood how they work. And the fact that actually, as Carol will probably say later on as well, is we have a lot of data from previous vaccines that work in the same way, and we know that they haven't had an effect on people's fertility in the future. And I think that's really important to consider, is even though this, you know, these vaccines have been rolled out quite quickly, they have gone through all those safety measures that we do, you know, we always do in other vaccine programs.
Yes, I mean, I was heavily invested in Michelle's future fertility, as I do wish at some point to be a grandmother. So I actually was quite surprised when she said this, but I realized that there was a definite wave of this fear about fertility running through particularly young people actually in their 20s, who are frontline workers, who are being offered this vaccine for their safety. And it's terribly important to remember that what we're trying to do with the vaccine is obviously prevent the spread and to prevent people becoming very ill. And although young people by and large aren't becoming very ill with the vaccine, I have seen quite a lot of patients in the reproductive population that are suffering now from long COVID, and they are delaying their treatment. They are still unwell, and they have many symptoms as a result of having had COVID. So they haven't necessarily been hospitalized or been into intensive care, but they have prolonged symptoms. So in my advice at the moment really is, if anything, if you're offered the vaccine for whatever reason, it will potentially protect your fertility rather than do the opposite.
And what about if you've had COVID? Is the vaccine still applicable?
So if you've already had COVID, the recommendation is to defer having the vaccination for at least 4 weeks. And you can have quite a strong reaction when you have the vaccine if you have it too soon, because you will have developed those antibodies. They're there. So really there's no rush to get the vaccine. In fact, we were recently offered the vaccine for all of our patient-facing staff, and those staff that had recently been infected with COVID have been they've been advised to wait at least 4 weeks, if not longer. So that's the advice with regards to COVID.
Yeah. So just to go on to the next question, one of the questions that we've also had is, you know, having the vaccine sort of before or during their cycle, will it actually affect potentially the outcome of their fertility treatment?
Generally speaking, at the moment, only 2 groups of patients are being offered the vaccine. And that's the top tier. So you've got all the frontline workers and people who are working in care homes, people who are working in the NHS, social workers, and people who are in the vulnerable category. So when it comes to people of reproductive age, there are clearly quite a number of patients that are now coming through, particularly frontline workers. And often you don't get a lot of warning as to when you're going to get offered the vaccine. So I've basically been saying to those patients, if you think you're going to be offered the vaccine, don't start a cycle, because it wouldn't be an ideal time to have the vaccine right in the middle. Having had the vaccine and talked to all of my colleagues who've had it, both at the Agora clinic and elsewhere, it leaves you with a sore arm. I had the Pfizer vaccine, leaves you with a sore arm, and the first 24 hours, you do feel incredibly tired, a bit flu-like. Some have had quite bad reactions and been off work for the next day or two. And I've always taken the view that, you know, if you are unwell during a fertility cycle, when patients ask me, will it affect my outcome? I don't know that it will affect how many eggs you get and how well they fertilize, but you're not on top form. And we want to feel on top form through that. You know, we've invested the time, we've invested the money. So I would advise you not to have it in the middle of fertility treatment, but we will come to talk in a minute about having it before and how long you need to wait.
Yeah, so on to the next one really is, for those who are currently being offered the vaccine, how soon after that first vaccine can they really start their treatment? You know, particularly, you know, first and second dose are kind of the 2 big questions.
And you've had lots of questions about this, and particularly as, you know, this all happened so suddenly. We were suddenly into the end of December, beginning of January, and all the frontline workers were being offered the vaccine. And they were, you know, they were quite right to ask us, because we needed them safe. So I basically recommended everybody to have that first dose. Now, at the moment, although, you know, the initial recommendation was that there would only be 3 weeks before the first and second dose, the government has stated that in order to vaccinate a larger proportion of the population with the first dose, we're going to have to delay 12 weeks for the second dose. So my second dose is going to be the first week in April. Now, so that's what, you know, that's what a lot of my patients are looking at. Do I wait until April before starting treatment? Certainly, you can start treatment now. If you're a little bit older, if you're perhaps approaching 40 and older than 40, as you see the time going by and the clock ticking by, that will make you anxious. You probably won't find a significant drop in your fertility in that 3 months, but it is quite an anxious time, and you may feel that it's better to go on and not have the second dose if you conceive, if you happen to conceive. We're about to talk about, you know, pregnancy and the virus, but you know, you might want to delay that second dose. But if your fertility reserve is reasonably good and you're under 40, I would say wait, have your second dose, and a week after you've had your second dose, you can start your stimulation injections. And the reason it's a week is that the first dose, it takes about 3 weeks to build up your immune response before you've got a decent level of antibody. But once you're taking your booster second dose, it's only about a week. I hope that makes sense to everybody, but you know, if you're a frontline worker, you can't risk being infected. It's too much risk. Get that vaccine if you're offered it or if you're vulnerable. And if you're a little bit, you know, unsure about whether you want to wait, come in, have a chat, because everybody's different. We go through each, don't we, Michelle? Everybody's different. We go through each patient, you know, one by one, and give you the advice you need.
And as you said before, for those patients of yours who have had COVID, some of them are obviously suffering from longer COVID, which may be affecting their delays more so than waiting for the vaccine, I presume.
Yeah, we've definitely seen that some people suffering with long COVID are actually, you know, have been infected at the very start of the pandemic and still are suffering very, very badly from these long-term effects. And because there's so little that we know about this long COVID, I definitely think it's worth getting that vaccine if you're in that position.
And the other thing I'd like to say is, you know, there is a big difference between men and women. So when you get COVID, it's not really likely to affect your egg or your egg quality or your egg numbers. But if you're a male and you get these high temperatures and you're really unwell, because of the sperm cycle being about 3 months, you could quite significantly drop your sperm count and quality in that next 3 months. And we're seeing it. We're definitely seeing it, without a shadow of doubt. And we know that for all viral illnesses, you know, any virus can affect sperm count and quality.
Shall I move on?
Move on to the next, please. That would be great.
So yeah, I know we sort of briefly covered it, but we said about the fact that it's probably not ideal to have your vaccine in the middle of your fertility treatment because of the reasons we said below. So yeah, the next question was, should I have the vaccine if I'm pregnant? Now this one is one that I think we sort of briefly covered, because if we have a patient who's come through, who's had their first vaccine, and then they have their treatment and they fall pregnant, there's a lot of questions just regarding, is it safe to have it during pregnancy? Carol can obviously expand a bit further on that.
So let's remember what I said before, is this is not a virus which is alive. This is a dead vaccine. We can call it non-live rather than dead, because it's a nicer way of saying it. It is identical in principle to many, many vaccinations that we have, and in particular the flu vaccine, which we actually actively encourage women when they're pregnant to have the flu vaccine, because getting flu out of pregnancy can be in young people quite a bad condition, but when you get it in pregnancy, it can lead to, you know, pneumonia, some very, very severe complications. So we encourage women who are pregnant to have the flu vaccine. The only reason that at the moment we're not giving pregnant women the green light on the vaccine is simply because a pregnancy is 9 months. These vaccines were developed in the second half of last year, and they just haven't been rolled out and trialed in pregnant women. So we haven't had the data through for that, the different stages of pregnancy. But if and I've put this on our website, if the Royal College of Obstetricians and Gynecologists and the Royal College of Midwives have clearly stated that if you are pregnant, you can have the vaccine if the benefits outweigh the risks. The risks is there is an unknown here. We haven't had this properly evaluated in pregnancy, and that is ongoing. It is ongoing because there are some people who will be having the vaccine in pregnancy. However, if you are somebody that is pregnant and you are continuing to work in the front line, or you're in one of the vulnerable risk categories, I mean, you have lung disease, you have heart disease, or you're immunosuppressed, you should have the vaccine if you're pregnant, and because the benefits will outweigh the risks. So it's on a case-by-case basis, and you would discuss it with your obstetric team, with your midwife, and they would offer you the vaccine. We don't know anything really, again, about breastfeeding. Is it fine to have when you're breastfeeding? I personally think it will be, that there isn't any strong evidence that this non-live vaccine could in any way be something you shouldn't have if you're breastfeeding, but the data is just coming through.
Has there been any data on people who have been pregnant whilst getting COVID in terms of any issues?
Yes, that data is coming through. And I think what we've really understood about COVID is that if you are pregnant, you don't seem to be more susceptible to COVID or to the worsening aspect of COVID. And there have been the odd case reports of babies who have become infected when COVID happens in latter parts of pregnancy. But the data is not showing, it is not indicating that pregnant women, unlike flu, that pregnant women are more vulnerable to more severe disease when pregnant. There was initially concern that it might lead to premature delivery, but I don't think we've got clear evidence of that now. And I think at the moment, we will not be vaccinating the pregnant population unless they fall into the vulnerable risk group. And it's the same thing, is that nobody has been told, when you turn up for your COVID vaccine, when was your last period? Could you possibly be pregnant? Because actually you might be. And when you turn up for an X-ray, if you need to know if it's an X-ray in the pelvic area of your body. They want to know, because X-rays they know could damage an early pregnancy. But because we're quite confident with the COVID vaccine, nobody is turning up for a vaccine and being told, when was your last period? Could you be pregnant? Oh, you could be pregnant. Please come again tomorrow. So I think that is probably a very strong signal that there isn't perceived a problem with having the vaccine in pregnancy, and particularly not in early pregnancy.
Thank you. And then our last question was, how soon after having COVID can someone actually start treatment?
So this is really, I continue to be educated. We have a very good consultant microbiologist, Dr. Bruce Stewart, who actually is very, very, is playing a very important role at East Surrey Hospital and leading on the COVID program there. So we were having this conversation about when we could advise our patients to start. If you've had COVID, the first thing to look at is your symptoms. It doesn't matter how long ago you had COVID, you must be in a good state of mind mentally, because any viral disease will leave you drained mentally, exhausted, poor sleep patterns. You must be in tip-top condition. So make sure your mental health and your physical health is back to where you'd like it to be. So don't rush back. You can actually, if you're relatively asymptomatic, start your treatment at 10 days or more after having tested positive. You have your self-isolation quarantine period of 10 days. Beyond that, you are not infectious. You will potentially continue to test positive. So there's no point in testing. In fact, the advice I've been given by Dr. Stewart is do not test. And in fact, there's a 90-day rule. You will continue potentially to shed the virus, but you're not infectious. Your body is shedding virus, but you're not actually infecting anybody else for up to 90 days. So that means that you're quite safe to come through treatment, quite safe to go to your clinic, and you're not going to infect other patients. And you're certainly not going to potentially pass on the virus to any pregnancy. And we've got the same rule for staff. You know, we have now introduced testing of our staff on a weekly basis. Anybody who's had COVID in the last...
Is the computer frozen?
I think it's slightly frozen.
I can still hear you. I'm sure it will come back in a second. Oh, I think it's frozen that end. There have been some questions that have come through, so I'm going to get
happy to.
Oh, there we go. You're back.
Hello. Am I back? Well,
you're back. I was just looking at the questions actually whilst the connection was coming back. There we go. We're back.
We're back. Sorry about that. So yes, I finished the piece on when we could start treatment. Perhaps we've got another slide actually, which I think we felt we'd like to share with you, Eloise. If you could pass the next slide on. Now we put this in because I think a lot of the questions that we're having from patients is around our policy, or different clinics are doing different things. We certainly felt coming out of the first lockdown, with the very low COVID rates that we had in Sussex, that we didn't need to test routinely our patients for COVID. We didn't have to do that COVID test. And we didn't feel that self-isolation was required. The situation has changed absolutely dramatically in terms of what was going on in mid to late December. And 3 of my staff, between Christmas and New Year, reported positive COVID tests, and they'd been incredibly careful. Just coming to the clinic, we wear PPE all the whole time. And then we saw what was going on. Brighton Hospital, absolutely full to the brim, full of patients with COVID, intensive care, absolutely full to the brim with so many sick patients. So I had to make a decision. In fact, you know, Michelle and I spent a lot of time between Christmas and New Year talking and talking to our team and making sure that we had a unified approach. We decided that for the health and safety of all our patients and all our staff, we would start obviously testing all our staff on a weekly basis, but we would test the patients. And we introduced a COVID test before the start treatment. Michelle, you talk us through the policy that we put in place. You there?
Is the screen frozen?
Well, if Michelle may have just frozen, but I'm going to talk you through it just because this is very important. For 10 days before you start your injections, we're advising our patients who are not frontline and who are not vaccinated to self-isolate. And that means that by the time they start their injections, they're very low risk of having COVID, but we ask them to do a proper PCR COVID test 72 hours before the injections start. Then they go through their ovarian stimulation, coming to the clinic in the normal way, wearing their mask, and we give them what we call a lateral flow test at the time of the trigger injection. Are you back with us, Michelle?
Yes, I'm back. Sorry, internet.
Yes, because yeah. So Michelle, you explain how we actually do it in terms of you're seeing the patients and giving out the test.
Yeah, so with our lateral flow tests that we've been doing, we felt that the safest way to do it and to just ensure that actually people's treatment wasn't going to be badly affected was to actually do it just prior to an egg collection, if they're going to egg collection. So if someone is producing sperm, we would also advise them to do one of these lateral flow tests. And these are a 15-minute test, so they're very quick response. And they give us that indication of whether or not that person has the virus. And it just allows us to kind of have that second check to make sure that they haven't somehow managed to pick up COVID in that first part of their journey, and then they know actually for their own peace of mind that they're going into their egg collection and going to transfer knowing that they have had that all clear. So we have found that has been really effective and just kept everyone really, really safe.
And then do people self-isolate whilst they're having their cycle?
Yes. So we've asked them to start self-isolating 10 days before their first appointment. So that might be usually around the time that they're going to start their stimulation drugs. And then they'll just continue isolating. Now they've got two options. They can continue isolating until their transfer. or they can continue after that point to see if they do have a positive test. And then they can then continue isolating until a pregnancy scan with us, or they could come out of their isolation and essentially just re-isolate for 10 days before their pregnancy scan with us, just to ensure that, again, we are sort of following those stringent measures the whole way through. And we have found that has been really, really effective. And one of the things that really reassured us that we were doing the right thing was we have had some people at that very first stage test positive. And if we hadn't been doing this, potentially we'd be, carrying risk. And the thing is that we've also noted is that actually people are asymptomatic as well. So people can slip through and could have actually come all the way through and potentially been at risk, not only to staff, but actually to other patients. So we found that this has been really good to keep the safety in the clinic and ensure that everyone has the best chance of having their treatment.
Amazing.
So we had, yes, six positive cases for January, and 2 were patients who had had their treatment in December and were waiting to have their pregnancy scan, and the 72-hour before pregnancy scan test came positive. They were asymptomatic. So we deferred the pregnancy scan. And in both cases, unfortunately, they had a miscarriage. And so I am concerned that, COVID is going to lead to poor cycle outcome if you get COVID during your cycle. And the way I've taken this small amount of data is I've written to local politicians and asked for fertility patients, doesn't matter if they're private or NHS, to be eligible for COVID testing, the normal NHS testing route. And I've also written now to the CCG and had discussions with the CCG and made the HFE aware, because it's my belief that if we are going to be bringing in testing in schools, we're going to be bringing testing in other places. The fertility sector is an area where we should be bringing in testing, because there's so much, there's so much importance on that cycle being right. If patients are asymptomatic and not aware that they're positive, those embryos that could be frozen could be when they're actually positive. They could end up with miscarriages. I think we've really got to action this and get this tested. I really don't want patients to be paying for tests. We don't offer, the payment of tests is not something we do at the clinic. They go to either a private centre or to the NHS centre. But I do think it should be encouraged, and hopefully by end of February, perhaps March, we may have this in place, and I hope it would be rolled out nationally. I would hope so.
Yeah, one of the biggest issues we've had with this policy and the strictness of this is actually it's really been affecting those key workers, those frontline workers who actually cannot take the time to isolate. So we have advised those patients that if they are eligible for their COVID vaccine, we've advised that if they are able to get both their doses, they wouldn't then need to isolate. But it is current advice that they should still continue doing bi-weekly testing with the lateral flow tests. So that is what our current advice is. So some patients have had to defer their treatment.
Is that because sorry, Michelle, is that because if you have the vaccine, you could still carry the virus without knowing?
Yes. So I think that the lateral flow test will continue for all of us in the healthcare industry, because we're also trying to keep. It's really also to assess the efficacy of the virus. So we're not too sure if the virus, when you've had COVID, it doesn't matter that you're positive, you're not shedding the virus. But we really do need to understand a little bit more about the vaccine. So that's why I think it's part of collecting data. Yeah. And going back to the healthcare workers. So what we want to try and do with healthcare workers, or those who have the vaccine, is make sure they have that first dose. And if they want to start before the second dose, they wait the 3 weeks and then they can just come through without self-isolating. And that's working quite very nicely, because I think pretty well all the frontline workers now, we're very close to having everybody vaccinated. So the ones that don't want to wait for the second dose and want to start treatment are now starting to come through. Others are preferring to wait, obviously, so they don't have that dilemma if they get pregnant of whether or not to have the vaccine.
Okay, great.
So I think we sort of covered what we had on the slide, but now we're ready to answer the questions.
Yes. Someone has asked, I am booked for a frozen embryo transfer this week, but I but offered the vaccine in work, would you recommend I have it? And I think you've answered that.
Yes, I would say if you're being offered it at work, it means you're in a high risk situation, and protect yourself. Yeah.
Someone has asked, if having the vaccine and pregnant after embryo transfer, should you wait until the first trimester ends to take the vaccine if you've had a previous miscarriage?
If you've had a previous miscarriage, should you wait until the end of the first trimester? I think it really depends on how risky your position is, in terms of getting COVID, because if you're not, if you're able to sort of work from home, there's a different answer to if you're front line. You know what I mean? I think the decision about having the vaccine is dependent on how exposed you are.
I think from my own experience of having had the vaccine, particularly with the Pfizer one, is the day after you do feel quite unwell. So my question, I suppose, to Carol would be, would potentially feeling quite unwell for a day have a bit of a detriment for someone who does have a history of miscarriage?
It's possible. I think the thing is, we don't know, but you'd kick yourself if you actually had the vaccine and then miscarriage. You'd say, well, it must have been a vaccine. Yes, I think most people get some. I haven't met many people who've actually had no symptoms at all from this vaccine. I often have the flu vaccine. I get pretty well nothing, but this one does actually knock you a little bit back. So you would feel, could that have been affected? In scientific terms, very unlikely. It's extremely unlikely. Your body's going into an immune response reaction. It's the same as if you get a cold in the first few weeks of pregnancy, the same sort of thing. And you don't necessarily miscarry if you have a cold. But if you did, you'd feel bad. You'd think, oh, what if I'd waited a bit longer?
That's good advice. Another question. I'm approaching 40 in 3 months' time and work within the NHS. In the last lockdown, I was redeployed to COVID wards and delayed starting fertility treatment. I'm now no longer treating COVID patients in my job and returned to my normal role and have received my first Pfizer vaccine. The delay of 3 months for second dose is causing worry of my fertility reserve. I'm considering not having the second dose and just getting on with IVF. Do you think I should wait for the second dose before starting?
So I would say to you, it's worth having a chat with your consultant at the fertility clinic, looking at your ovarian reserve, your AMH level. What was your response? What's expected, and if you wait 3 months and you've got quite a lot of eggs, then you're probably not going to see a difference. But if you are at the lower end of the egg reserve, I would probably say it's worth thinking about starting sooner. And you're not necessarily in a high risk situation now. The first dose of the vaccine will have given you some protection. We probably expect about 70% chance of protection. So that's a one-to-one discussion with your consultant on your egg reserve.
And just to add to that, Carol, you can probably clarify a bit more on that, but someone could have their first dose and should they fall pregnant, they can delay, I believe, their second dose until they've given birth. Is that correct?
Yes, and I think one of the things that I'm thinking is they're going to probably start modifying that second dose. I think there's already talk about the boosters being modified to deal with the new variants. So I don't think it's the end of the world that you don't get the second dose, because you've got some immunity from the first dose, but they're now trying to rapidly develop, booster second doses that can give you strong immune response, to particularly these, new Brazilian and South African variants. So delaying until the end of pregnancy might not be such a bad thing.
Another question. My partner is a key worker, but they're not. Does he need to self-isolate with her for 10 days before starting the injections?
Yes.
So it is. Yeah, it is. Well, we've had partners just staying in different houses or staying in different rooms and trying to so you can do it.
I think the key question is if they want to be potentially present at the transfer, then they would need to isolate. And I think that's where we've been discussing everything on an individual basis to try and find out how can we make this work best for our patients and find kind of the easiest solution for them. So if they were wanting to be present at that transfer, then we would definitely say that they would need to self-isolate. But as Carol said, we have had some patients who've kind of separated for at least part of their treatment in order for them, you know, their partner potentially to continue working whilst they sort of start the first step of their isolation and potentially their first scan.
I've got to say that we're doing this in our clinic because I personally believe that the emotional and financial investment in an IVF cycle is huge. And if you did a COVID test at the start of treatment, but you weren't self-isolating and you were going out to work, there's very high risk at the moment with the levels we have of COVID in the community of becoming infected. Whereas if you're at home and you're safe and you're getting your deliveries, then by the time you get to egg collection, we've not had any positive lateral flows. At the time of the trigger, none of our patients have tested positive. So they've been able to have a confident, egg collection and embryo transfer, knowing, well, they've protected themselves. They've not got the virus through that treatment cycle. So that treatment cycle is as good as it could ever be. Whereas if you do go out, I have made some exceptions because I know some of my patients want acupuncture because they can walk to see their therapist. Acupuncture is beneficial for them, and they feel better. They feel that the acupuncture may benefit them. Those are the sort of exceptions where we identify what they're going out for. Every day, go out for some exercise, but do it in a safe way, because it's important to keep your mental health in tip-top shape when you're going through an IVF cycle.
And the what you're doing at the Agora in terms of the safety measures, is that typical for other fertility clinics as well?
I can't speak for other fertility clinics because, as I say, the self-isolation part is probably not necessarily what every clinic will do, because some clinics will potentially just want the numbers coming through their clinic. They'll want to have as many cycles through in the month of January or February as they can, whereas I've taken the view that you can always defer your cycle until the COVID rates in the community are down. I think we are dealing with such high rates and such unknown transmissibility. We know the Kent variant, which is rife in Sussex, rife in our area, is highly transmissible. We know that even potentially the face masks that we're wearing when we go out to the shops is not protecting us. I know from the patients that are currently inpatients in Brighton Hospital, some very ill in intensive care, often they've said to their consultant, all I did was go to the shops. These are not people that are going to raves or having parties or meeting friends. All they did was go to the local shop. So it's not, that's why we felt that encouraging patients to stay at home during the treatment cycle was probably the best action to take for the months of January and February. We may take our restrictions down a little bit by the time the schools go back in, hopefully in early March. Then we can see, we can see the numbers coming down in the community. I think that will be a time when we can start to say, well, make your own judgment on this, make an informed choice. But to protect all the other patients coming through the clinic, I feel this is the right thing to do.
Absolutely. And another question, with FET, are the isolation rules the same? If you've had both doses of the vaccine, do you need to self-isolate before treatment?
If you've had both doses of the vaccine, you don't need to self-isolate at all. So once you've been vaccinated, if you take the first dose and you're a frontline worker, you can come through after the 3 weeks after that dose. You've got some level of protection. You're testing twice weekly. So you will let us know if your test is positive, but we believe that it's the right thing to allow you to come through. You're doing a great job, come through. But obviously, these are people who are working in situations where they have appropriate PPE, they know the safety rules, and apart from going to work there, I'm presuming they're not doing anything at high risk, and they've got a vaccine on board. Okay. And so frozen cycle, I think because the frozen cycle is a shorter cycle, we don't scan a patient until usually, several days into their cycle. We work backwards from that point, 10 days beyond, before they come into their clinic for their first scan. So the self-isolation period for a frozen cycle is much shorter.
And they've also asked, does that include partners too?
So we want to include partners at transfer, but obviously they need to be on board with the COVID test. As long as if they want to be involved and come into the room for the transfer, which we've been able to do all the way through last year, since the rates are higher, we are asking both of them to test. And that's going down fine, isn't it, Michelle? I mean, they're coming on board, and what are your conversations like with them?
Well, I think because it's I think this whole process, because of how we've had to make everything about, you know, everyone should attend their appointments as advised by the HFEA, ideally solo. I think that has made that whole journey quite difficult for some people, not being able to have, you know, their partners there for support. So, you know, we have felt that we've needed to review particularly that point of transfer as quite a pivotal moment for partners being able to attend. So we have very much advised that if partners are able to follow those rules up until that point of transfer, then they would be able to come along and attend that appointment.
Great, thank you. I'm sorry, I've just opened up another chat box of questions. There are lots of questions coming through, and I'm aware of your time.
I saw one is coming in, which I just saw the word costs, and I think we must address this. I think it's really important to address this because we as a clinic took the view that COVID has led to a lot of financial hardship for many people, not everybody. It's led to a lot of emotional stress, and we're all suffering from an element of post-traumatic stress because we weren't expecting this a year ago. And we're trying to make that burden of the cost of treatment, if you're not NHS funded, you know, as affordable. We're trying to make everything as affordable as possible. So we've not changed our prices. We've still got the same costs for all our treatment cycles as we had in 2018. We didn't use, you know, the extra PPE cost or, you know, all the other tests we have to as an excuse to put up our prices, because we feel that what we've got to put in at the moment with the lateral flow tests and other tests is a temporary measure. It's responding to the local situation, and it's responding to, say, you know, preserving our NHS and all the things we've been asked to do. So at the moment, we're not a COVID testing centre, and we haven't done, you know, some clinics have charged patients quite large prices for a COVID test, you know, PCR test. We haven't done that. We you know, you can choose if you want to go to the NHS testing centre or you want to go to a private centre. As I say, I'm trying to make sure that patients are you know, 100% confident they can go and have an NHS COVID test before a fertility cycle. And the only thing we've done is we've put an admin charge or an admin fee of £50 onto an IVF cycle. It's a typical example for both partners to have the lateral flow test and to cover that cost. Currently, we just looked at our January, you know, figures. It's an extra £4,500 to us to provide, you know, to test all the staff, because we're not an, you know, an NHS-based unit, so we're not being provided with free lateral testing for our staff. We're doing it all ourselves, and to cover the, you know, all those tests. So this is a not-for-profit £50 fee that is just covering the, you know, that safety measure we've put in before egg collection. And it's a considerably lower sum than if you had to go out and buy that lateral test. But we felt this was the best way of handling it, because hopefully in a month or 2 months we see progress with COVID. Either we will have the proper government support for testing that I'm campaigning for, or we'll be able to reduce some of those measures, and the costs of an IVF cycle will be exactly the same as it was a year ago or 2 years ago for our patients. And I think that's the right way of approaching it.
Because if you go for an NHS in the post or testing centre, it can take days to come back, can't it? It took me 5 days to get my positive test back.
Yeah, we have found, particularly with the postal ones, they do take up to 5 days. And I think that is just because the cases are so high at the moment. But having had discussions with sort of the local testing centres, you know, they are hoping as the cases drop that time frame will be reduced back to the normal 72-hour maximum turnaround. But it just has been, I think, quite overwhelming for them at the moment. But yeah, as I say, hopefully that will start to come down.
But when you're doing the test at your clinic, how quick is the turnaround for people to find out whether they have COVID? What did you say it was?
So with our tests, so the lateral flow tests are a 15-minute rapid test. So we do usually advise that our patients, for the very initial test that they have before coming to the clinic, ideally, for those patients who are able to access it, we ask them to do a PCR test. And that is because actually it's much better to use that one. And the tests that we use are very marginally below that. So ideally, we like to have that one that can measure a much lower viral load. So essentially, it's to catch people who are kind of either side of that peak much better than the ones on the lateral flow test. Having said that, the reason that we have used the lateral flow test that we have been using the ones that have the highest specification on them, just to ensure that, you know, we do have that safety there, to help people know that, you know, they haven't got COVID when they are getting to that really important point of egg collection or transfer. So yeah, that's the reason that we've kind of chosen to do those two as we have, really.
Thank you for expanding on that. I'm sorry, I've missed a comment here. This lady says, thank you so much for such a great informative session. May I ask a broader question, since I understand now the COVID aspect? I'm someone from outside of the Brighton area, but if someone was to come to the Agora for private fertility treatment, what is the wait time at the moment for taking on new patients?
So we don't have...
We don't have a waiting time. What's been happening over the last, I feel really bad because I'm a doctor that hasn't been able to go out and help the sick patients on the intensive care wards. But I think we've all felt our role has been to help in the fertility sector.
Yeah,
and
I think
we work long hours.
I think one of the things that we said as a team is we've all worked extremely hard on our policy to ensure that we are still able to offer our treatments and actually to help people come through, particularly those who potentially have a reduced ovarian reserve, or potentially, you know, there are other issues there that actually they need to start their treatment quite soon. So we've worked quite hard to make sure that there isn't waiting time because of COVID, and because we moved actually last year to quite a lot of our tests and also consultations becoming all virtual. So we're offering still blood tests can be done through the post. Sperm assessments can actually be done in the comfort of your own home, and all of the assessments with the doctor, the consultations are all done via Zoom to kind of actually reduce, firstly, you know, having to visit the clinic, and secondly, just to actually reduce that time from making an initial inquiry and just wanting to get your investigations underway. After that, to actually start your treatment, it's almost, you know, it's a couple of weeks and you're sort of set up and ready to go, really. Obviously it depends on people's circumstances, but we've been very, very grateful that we haven't had to kind of create a long waiting list for people, which is really good.
Fantastic.
So we definitely see
here, so that it can find you.
We haven't talked about this, but we've also seen huge numbers of patients coming to us for fertility MOTs because it's actually very easy to do. We either do home testing or patients come to the clinic. When they come to the clinic, actually they come up to collect one of these lateral flow COVID tests. They go down to their car, do the test. As long as they're clear, they come up and have whatever a test it is, blood test or whatever. That's the way we've been doing it, to be able to get patients to have, you know, to have whatever test they want safely. And then we have the Zoom, and I run the virtual open evening. Every 2 weeks I do either same-sex couple or a heterosexual couple open evening. I'll be doing one tomorrow night if anybody wants to join. And then we do, after that, we do one-to-one Q&As. We don't get them all done in the evening, but that's the way we've found, is that we can educate our patients about their options, and then they can come through, have some tests, and then they can decide to come through for treatment when they want, which is, you know, they could decide, well, you know, I'd rather wait for the COVID to sort of be a little bit, you know, calmer than it is now. And we have had, you know, we were able to treat all the NHS patients that were referred to us last year, and all the private patients apart from that initial coming out of lockdown, without any delay to you know, there was no waiting list.
Mm-hmm. Brilliant, thank you.
And just to add to that as well, we've actually, all of our support options have been also available virtually. So we offer a regular support group that again has just been done over Zoom. Our counsellors again have been doing everything over Zoom and telephone. So actually we've tried to make things as accessible as possible during the time that actually things have, just haven't been quite the norm, just to help, have that support structure in place, which without, seeing as many people as you do normally, I think is super, super important.
Definitely. Christina, I hope that answers your question, and there are the Agora's details if you want them. We've had some more questions, and I am aware of time, but there is one that I've just seen, which is a very good question around intralipids and steroids at the moment. What's happening about that?
It's a very difficult time to be using intralipid. We have to say we try to discourage use of intralipid and steroids at the moment during COVID, but we understand for some patients this is a key thing that they believe will help them to conceive. I think, I'm not going to have a whole argument about, where the pros, the rights and wrongs of natural killer cells. I mean, I believe there are some women with an immune reaction to pregnancy where dampening the immune response is going to be their only source of hope. And I have certainly seen some patients that way. I'm not sure that the actual test, the natural killer cell test that we currently use across the UK and throughout the world is the right test. But I think there are some patients for whom the treatment is the right treatment. And I think, if you can't defer your treatment or you really want to come through, we are, self-isolate, stay at home, just come in, COVID test, be safe. We obviously risk assess everything with you, and we get patients to sign a consent form that they fully understand the risk implications. We've had very few patients, but we've had patients come through quite safely who've had that treatment.
That's good to know. Everyone has said thank you so much for a very insightful conversation and for answering all of these questions. So thank you for your time this evening. If I've missed any questions, because I'm working off 2 chat boxes here, then please feel free to speak to the Agora directly, or you can send them to me and I can pass them on, whichever works for you.
Thank you very much, Eloise.
Thank you both. Very nice to speak to you. Bye-bye, everyone. Thank you. Bye-bye.